We begin with a formal welcome to everybody by our President, Prof. Agarwal from PGI Chandigarh. Dr. Neelam, please.
Good evening, everyone. Once again, on behalf of Stillbirth Society of India, I welcome you all to today's very, very exciting session held by Committee for Study of Genetic Causes of Stillbirth. And thanks to Dr. Shubha and Dr. Shailja, who have made so much effort, and I think it will be worth it. It's going to be a new, exciting update. And I welcome everybody, all of our speakers, panelists, chairpersons, and all the audience. And I hope that all of us will benefit from this webinar. Thank you.
So may I now request our Vice President, Dr. Lozak, to please introduce Dr. Sunil, Jaiman, our international faculty.
Thank you. I was asked to introduce you, Sunil, so I thought it was a delight and a privilege. So he's been associated with us for a long time. He's a good friend of mine, and everyone knows him as the placental pathologist. He's currently working as the assistant professor in the Institute of University of Medicine, main state of University of Medicine in USA. But he has been with us for a long time, and he was the one who introduced us to placental pathology. And he has many achievements, 42 publications in placental pathology is an absolutely impressive achievement. He's got various awards. He's currently the editorial board of Indian Journal of Pathology and Microbiology. What you can see on the slide is his work and his research work that he has done, his interest. We have done few papers together and few CPC meetings together, and I always remember those days, Sunil, and it's just that very impressive. I had no idea how to read a placental report before I met Dr. Sunil. But what I can tell you is that he's an absolute, very impressive person to meet with. Anyone who meets him, would not forget Dr. Sunil Jaiman. I remember many events where I've sent a person across and he makes the other person feel so good. He's just very passionate about his work, a poet. Okay, many of you don't know that, and an absolutely brilliant human being. It has been an absolute pleasure to be a friend to Dr. Sunil Jaiman, and I now invite him to take over the proceedings from him. Thank you.
So as the Secretary of the Stillbirth Society of India, it's my privilege to introduce members of the Genetics Committee to all of you, though they do not need any introductions. There's lots of academic glamour today. They're all pioneers in their field. And Dr. Shubha requested me to keep the introduction short, but I don't think I'll be doing justice to their eminence if I do not introduce them formally. So we have as the chairperson, Dr. Shubha Phadke, and she's DM Medical Genetics, Professor and Head, Department of Medical Genetics. And her special areas of interest are pre and postnatal dysmorphology and genetic diagnostics, psychosocial issues in genetic counseling. And she's also a great medical educationist, teacher for DM Medical Genetics program for the last 25 years. And she has contributed a lot to the ICMR and DBT as member of the research committee. Almost 300 publications, book on genetics for clinicians, founding president of the Society of Indian Academy of Medical Genetics, editor of genetic clinics, and on the editorial board of American Journal of Medical Genetics and Indian Pediatrics. And she, for all her services to genetics, she has received awards like the Har Gobind Foundation Fellowship, International Scholarship of Clinical Genetics Society, as well as the prestigious IC Verma Outstanding Researcher Award. Thank you so much for being with us, Dr. Shubha. And I'm also very proud to introduce Dr. Shailja Singh. She's the secretary of the society, of the committee. And she's, I'm proud to tell you all that she's also from Jain Medical College, our alumni, and she's a consultant maternal and fetal medicine, Spersh Maternal and Fetal Care Clinic, working in Muradabad, an area which lacks proper care, and she's doing a lot of service there. She's also FNB in high-risk pregnancy and perinatology. Her area of interest is rheumatologic disorders in pregnancy. Apart from that, she's a very active member of the Society of Fetal Medicine and has contributed at various national and international level conferences, as well as contributed chapters to books. It's a pleasure to introduce, and I'm really proud that she's with us, Dr. Ratna Puri, Professor and Chairperson, Institute of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. She is member of Undiagnosed Disease Network International, USA, member Diagnostic Scientific Committee, International Rare Diseases Research Consortium. She's member panel of experts, WHO Collective Global Network for Rare Diseases, an activity of Rare Diseases International. More than 130 publications and many ongoing research projects. And she's also been awarded for all this service to genetics by the Dr. I.C. Verma Outstanding Researcher Award, Dharamvira Award of Excellence, and Young Investigators Award from Tokyo, Japan. We also have Dr. Katta Mohan Girisha, Professor and Head of Medical Genetics from the prestigious Manipal Academy of Higher Education. He's also interested, his area of interest is skeletal dysplasia, pre and postnatal dysmorphology, and he's been trained as Mount Sinai in the same. More than 234 papers, research projects, and also established the first Master of Science program in genetic counseling in India. And he's also a member of various societies and contributes as associate editor, section editor to prestigious journals, as well as founder director of Suma Genomics Private Limited. Dr. Shagun Agarwal is also with us as additional professor, Department of Medical Genetics, Nizam's Institute of Medical Sciences, and adjunct scientist for DNA fingerprinting and diagnostics. She has more than 60 papers and contributed with the chapters in various books, research grants, and also she's associate editor of Genetics Update for the Next Generation Clinician. And her area of interest is genetic characterization of fetal malformation syndromes. She's also the discoverer of novel genes, coordinator of clinical genetics and prenatal genetics fellowship, treasurer and executive committee member of the Society of Fetal Medicine. Dr. Deepti Saxena is associate professor, Department of Medical Genetics, SGPGI, Lucknow, and her area of interest is again dysmorphology, skeletal dysplasias, prenatal diagnosis, and reproductive genetics. She is also published a lot and has various research projects going on for her. Dr. Chitra Janu is consultant fetal medicine at Dr. Chitra's Fetal Medicine Clinic, Agra. She has worked at various and has a vast experience of working in New Delhi and Kerala, as well as she has various podium presentations, and her area of interest of fetal medicine and invasive procedures. Again, I'm really proud to introduce Dr. Anupriya Kaur. She's also a JNMCite, Associate Professor, Pediatric Genetics, PGIMR, Chandigarh, and she's trained in next generation sequencing and its applications from Cleveland, Ohio, USA. She's gold medalist as an undergraduate at JNMC, a UNICEF project research coordinator, 30 papers and chapters and books and various projects, and section editor for Oncogenetics, Indian Journal of Medical and Pediatric Oncology. And we have Professor Aradhana Singh, who Department of Obs and Gynae, BRD Medical College, Gorakhpur, and she's contributed a lot as scientific secretary, executive body member, life member of IMN, various other organizations, and received prizes like the Foxy C.S. Dawn Award and for her paper presentations as well.
Thank you very much for the introduction, and I'm very happy to have such a great team to work with. And this is the first session, which we thought that it will be very important to have a panel discussion form rather than giving a total talk, because there are many different areas and lot to be discussed. But at least this session will serve as an introductory session, and you can see below all these various genetic investigations. And sometimes I think non-genetics clinicians feel frightened that what all these things are and why, which to be done, exome and microarray and everything is changing again and again. So we can have detailed case-based sessions about investigation sometime other. But today's session is basically try to identify genetic etiologies of stillbirths. The panelists have been already introduced, and I'm very happy that the panelists include very senior experienced persons, dignitaries in this area, as well as young, bright, young geneticists and fetal medicine specialists who are keeping themselves updated. So I think this is a very balanced type of panel, team of panel. And coming back to the topic, stillbirths we were discussing that before this committee came into existence. I think stillbirth is very, very painful for doctor as well as clinician. But many times it is sort of put under the carpet and nobody wants to talk about it much. And this society has really brought this area into forefront, and everybody concerned are really started discussing and putting more attention to that. I'm not saying that people, obstetricians were not, their always aim is to have a live birth, but probably to discuss something after the stillbirth has happened was not really being done. And that's why we sometimes get such referrals as shown in the pedigree. There were 2 consecutive stillbirths, and there is consanguinity. And many times it's said that fetal distress or 2 neonatal deaths because of septicemia. So this is really unlikely. Now the medical care, perinatal care, antenatal care is improving so much that the perinatal causes of stillbirths are getting reduced. And hence we have to think of genetic etiologies as an important cause, because they could be contributing a lot to the stillbirths in this era, where obstetricians are taking very good care of during antenatal and perinatal period. There are a lot of checklists and algorithms, and a lot of things are being done. So this should not happen. So the objective is that 2 recurrent stillbirths should not happen as much as possible. And here the possibility of genetic etiologies is very high. Of course, non-genetic causes like preeclampsia, syphilis, there can be many other causes which also can recur. But here mainly we want to think of genetic etiologies. And I would like to first make it clear that genetic disorder does not mean that always there is positive family history. There will be always first individual with genetic disorder in a family. Secondly, it doesn't mean that there is one genetic disorder in the family. That means that it will always recur. The risk of recurrence could be 0% or as low as 1%. Then it also depends on the clinical presentation. So we have to find out what is the clinical presentation and evaluate. Here the clinical presentation is death. So we are thinking of something where nothing can be done for that particular individual, and all the investigations are for the family so that they get a next child which is normal. And then for this particular presentation, etiology, when you consider there are thousands of etiologies, genetic and non-genetic. And this is a diagnostic challenge, that what is the cause of, or what was the cause of stillbirths. So we have fetal autopsy becomes a very important tool for identifying etiology of fetal autopsy. And we had been doing fetal autopsy for many, many years. And those who had trained with me, like Girish, Shagun, Ratna, a lot of people, they have continued to do, and they have experienced a lot of experience of doing hundreds of fetal autopsies. And these are some of their publications. And I would again like to tell that Dr. Sunil Jaiman, his expertise in fetal autopsy, he is expert in the area of fetal autopsy, and his expertise is unmatchable. And I again thank him for joining this particular panel discussion. So now coming to the starting the discussion, I would start with Dr. Ratna Puri to give us some idea about various causes of stillbirths and their relative contributions according to the published literature.
Thank you very much, ma'am. And at the outset, I'd like to thank the Stillbirth Society of India for this wonderful opportunity and the the spectrum of people who are involved in this. So to jump straight to the question, that normally when we think about the causes of stillbirth, to put it in a logical pattern, it is maternal, fetal, and placental. So the maternal causes, there are some risk factors, they're not specific causes, and they include parity, like more than 3 or nulliparous, or very young or very old women. They also say the Black race has a higher risk of stillbirth. Then amongst the other maternal causes, we have if there is drug abuse, cocaine, toxins, other toxins, or smoking, because they can cause abruption, placental abruption. If there is obstructed labor, preeclampsia, any intrauterine infections, and I'll come to that a little later. Then when we come to the fetal causes, we have congenital anomalies, and these constitute to about 15 to 20% of stillbirths, and most of them are major malformations. So they would be abdominal wall defects, neural tube defects, a Potter sequence, which usually happens if both kidneys are either agenesis or they're non-functional, wherever there is bilateral renal involvement, or a lethal skeletal dysplasia, an amniotic band syndrome, a major cardiac anomaly. Now, most of these congenital anomalies are not those that are associated with chromosomal disorders. The second group is those of chromosomal disorders, which are found in up 5 to 15% of as causes of stillbirth. And they could be in the absence of any anomalies, or they could be associated with anomalies. And we know that many chromosomal disorders are associated with intrauterine growth restriction. But it's interesting to know that the commonest chromosomal disorders that can have stillbirth is trisomy 21, trisomy 13, 18, and monosomy X. And this is where we've used, the traditional techniques of either QF-PCR or karyotype. If we use microarray, the yield goes up much more. So that is really the recommendation, that we can use microarray, and it has a better yield also than karyotype, and that will be discussed later. There are other genetic monogenic disorders like long QT syndrome, and that is something we should think of, because these are treatable disorders. These are disorders that have risks for parents and other family members. Infections.
Okay, Dr. Ratna, maybe we can, we have some of these cases in our
during the
discussion.
Thing. Okay.
So maybe I would like, as an obstetrician, Dr. Amita Pandey, because what cases we get for autopsy, Ratna, we have some bias. They may be more likely to be genetic, but really in obstetric setup, I would like to ask Dr. Amita, what is their experience about incidence of stillbirth and various etiologies, sir?
Very good evening to all of you. At the outset, I would like to thank Dr. Tamkeen and the Stillbirth Society of India for making me a part of this panel discussion. Dr. Shubha, now as you have mentioned rightly, I work in a tertiary care center, and the spectrum of patients presenting to us with stillbirth is entirely different. First of all, let me tell you that despite the fact that the incidence of the prevalence of stillbirth in India is reported to be around 13 to 14%, but in a tertiary care center like ours, we get a stillbirth rate of around 30 to 35%. This is significantly high because most of the patients who come to us are referred with an IUD to us.
So Dr. Amita, what do you think that how many of them would be really because of perinatal causes, or because they didn't get a good perinatal treatment?
Yes. Yes, a significant proportion of these cases are because of improper, inadequate antenatal care.
Is there any data published?
Yes.
About what could be the perinatal causes?
We have seen that more than 50% of the cases of stillbirth are because of improperly managed labor and delivery cases leading to perinatal asphyxia. The second very common cause that we have seen is either preterm delivery or severe FGRs, which is very common. Then maternal complications like hypertensive disorders of pregnancy leading to abruption and uncontrolled diabetes mellitus also contribute significantly to stillbirth.
Do you think you can have some assessment. It's like, I'm not sure whether my question is right, but how much many of them may be genetic or maybe malformation, just a rough assessment.
I feel from amongst the entire cohort of stillbirths, I think around 20% to 25% could be because of genetic conditions, malformations, and infections also leading to high drops.
Okay. So naturally, we are immediately looking at the baby. One may not be able to decide whether it is a genetic or not. Hence, probably
Absolutely.
autopsy of all fetuses is very, all stillbirths is very important. We cannot really say attribute without just based on history that this could be perinatal insult. So I want to ask Dr. Ratna that how does fetal autopsy help in identification of stillbirths? So any number of cases and percentage, what if you want to say?
So we put some data together, and this was about 1,000 cases. There were 903 cases. If you could go to the next slide, because we always felt that the parents wanted to know, you're doing an autopsy, how are we going to be helped? What is the diagnostic yield? So if you just see what I have circled, there were about 300 fetuses with IUD, and our breakup, what we identified there. Now this is up to about 2014, and it was about 10 years data. 6% were chromosomal. There were birth defects, which could be isolated or maternal multiple malformation syndromes. There were about 13.6%. 46% were placental, and the miscellaneous ones, there were 3 which were post-amniocentesis IUD, cervical incompetence, twin, and a parvovirus infection. And within this is a very selected cohort. So that's why the diagnostic yield is high.
Still, it means 70% of cases of fetal autopsy can give a diagnosis or probable diagnosis, and this is very important for helping the family to prevent recurrences. As you, Dr. Ratna said, that one of the important causes is lethal skeletal dysplasia, and I would like Dr. Shagun to tell how one can identify lethal skeletal dysplasia. It's not really malformation. You can see many times it's not no external malformation which can be easily seen. So Dr. Shagun may like to.
Thank you, ma'am, and thank you for the society for including me in this panel. In fact, there are around 100 skeletal dysplasias which are lethal in the perinatal period, and they can present as a stillbirth, both starting from as early as first trimester to anytime in the third trimester. But these are some of the causes which can actually be somewhat easily picked up if we just take a look at the baby. So there are some very striking things, like these babies would have short limbs, sometimes with some bending also could be there. Then often they have a short or a narrow thorax, and sometimes in certain skeletal dysplasias, there could also be some malformations like polydactyly or a cleft lip, as we can see here, or certain other external or internal malformations. But it's basically the short limbs and the narrow thorax which would immediately lead you to suspect that this is probably a skeletal dysplasia.
So how to confirm the diagnosis?
Yes.
Because what I remember in 89, when I had seen first case of short rib polydactyly X-ray and the baby, I had to go and back and see very many pictures of the fetuses at 20 weeks or at 30 weeks. How long are their limbs? Because short limbs, it's easy to say, but how short, when you call short is very difficult, because newborns, then we have seen normal newborns, but really don't ever realize what is the length of their limbs or where do they reach. So many times, even if we do not have clue, every fetus can be assessed for possibility of lethal skeletal dysplasia, because their chest is so short, narrow and small that lungs after birth are not compatible with survival. So how to confirm the diagnosis in suspected cases or every case probably?
So one thing, of course, again, as ma'am, you said that it's like sometimes very difficult to see the shortening unless it's really short. So unfortunately, now also in autopsy or in fetuses, we don't really have normograms for limbs. But in ultrasound, at least now we have various normograms by which we can actually find out whether the baby's bones are short and what is the degree of shortening. And but autopsy, still the diagnosis of a short limb is more subjective. So in some cases it can be very short, as we can see in the last fetus here on the right side. This is a baby with the skeletal dysplasia called as achondrogenesis. And this is one of the skeletal dysplasia with almost very short limbs, the shortest limbs basically. They can be even shorter than what is seen in this baby. In fact, you would just see probably the hand attached to the shoulder kind of, I mean, that much short. And there could be others.
Even if limbs are not short, sometimes, if it's not obvious, if you do radiograph, can it help? Because
Yes, definitely,
one radiograph of each baby
yes,
is
definitely.
very important.
So the most important modality, in fact, to make a diagnosis of a skeletal dysplasia is a radiogram, and that an anteroposterior as well as a lateral view of the baby. The whole body of the baby should be taken, and it can say immediately many times give you a diagnosis, spot diagnosis for a trained perinatal pathologist or a geneticist. So you can see things like what you're seeing in the first X-ray, a very short kind of a thorax, and also.
Dr. Shagun, maybe it's some, this one, this thanatophoric dysplasia, not really, probably some typo, this thing mistake shift ho gaya. So this is, as you have said, you have showed achondrogenesis, and you can see obviously absent ossification of vertebral bodies. So just ignore this one.
And here we can see the very short ribs. In fact, this is classical of the short rib polydactyly conditions. There again, there are multiple types of short rib polydactylies, but you can see the extremely short ribs.
So
they are
basically,
not even...
if you get, Dr. Shagun, if you get only photograph and X-ray of the fetus, and the fetus is not available for autopsy, do you think you can make etiological diagnosis in many cases?
Yes, definitely, ma'am.
That is very important. So everybody, if you feel that the fetus is not, cannot be sent for autopsy, or the family is not agreeing, then just one photograph and one radiograph would be very, very useful. So again, another question to obstetrician, Dr. Aradhana. What is the role of obstetrician to determine the cause of stillbirth? And do you consult pediatricians for evaluation of stillbirth? You always call to prevent stillbirth or prevent neonatal death, but do you show the fetus, stillborn babies to the pediatrician? Dr. Aradhana, please.
At our center, every delivery is attended by a pediatrician, be it an IUD delivery or stillbirth fetus. It is attended by a pediatrician, and pediatrician also evaluate the baby. And
that's very important message for all obstetric centers.
Yes, ma'am. And as for the role of obstetrician, in case of any stillbirth, first we take proper history and examination is, I think that is the most important, and that is what is going to help us or anyone in a very low resource setting like our government hospitals. We don't have facility for high-end genetic tests, and we have to go to the private labs for those genetics, cytogenetics tests.
Radiographs,
and even
radiographs will be
yes,
can be done.
Yes,
can they be done 24 hours a day?
Yeah, that is available 24 hours a day.
That's a very important point. And mobile photograph in the mobile by the patient or doctor, that is very, very important.
We take photographs of gross examination, photographs and radiographs. That much we are able to do. And
and maybe again stressing placental examination and histology.
Examination of placenta, and we sometimes take segment of cord also, ma'am. For those who parents are, when they are convinced for cytogenetic test, we take the sample of cord.
Okay, that's very nice. So again, to a fetal medicine specialist, Dr. Shailja, do you advise families to get autopsy done in stillbirths, and how to convince them for fetal autopsy?
Yes, ma'am. Thanks for putting up this question and allowing me to give my side of story. So, ma'am, in my case scenario in which I work in, I get patients in two clinical situations. One in which I diagnose an ultrasound. There's a finding in ultrasound, and we know that the baby is going to have a bad outcome, like in a severe early onset FGR or kind of early early lethal skeletal dysplasia or some other findings. So in this case, we get ample of time to counsel the family and convey the plan to the obstetricians as well. But the other scenario in which I come across with the patients, like they come for in emergency just for the documentation of a stillbirth. And quite a few patients, mainly in third trimester, and they come, I mean, the families are not ready to listen anything. They are agitated in a mode of denial. And the little bit time I get to spend with the family, I rather concentrate on obstetrical management, like answering questions like mode of delivery and I mean, expectant management, I mean, the obstetrical management.
I think
So coming on to
I can understand the situation that, but in that situation, I think other than the father or mother who are very in the very sensitive mode in India, there are usually some relatives are there. Maybe in India, like all relatives interfere in between each other's lives, and they also help each other. So it will be little better, because to talk about autopsy appears very callous at that time when the family is undergoing very serious emotional trauma. But I think it will be useful if you talk to other relatives, and sometimes I think that may also work.
ma'am, actually they just come for delivery. The
I
main
know,
purpose
but
at that
the
time.
point I want to make is that we have to make every
Yes,
effort, and maybe
two.
rather than disposing the fetus within immediately, if everything is like if you take 1 or 2 hours to get the lady settled and everything, and then probably you can really talk to them again. And that if you are compassionate and they understand that you are very concerned about the family and unhappy about this sad outcome, I think that is the way to try to make a good rapport and try to convince them. Secondly, I want to here again stress that in addition to these, they're the fresh stillbirths. So lethal skeletal dysplasias are fresh stillbirths. And here probably we have to, you also would face a problem that baby was all right till they came. And then immediately after delivery, the baby did not take breath or immediately died. So I think because lethal skeletal dysplasia cause fresh stillbirths, it's very important that they should be evaluated, and you have to make every effort to convince the family. And I think gradually there will be better awareness amongst the people. Now coming to how the autopsy to be done, best person to tell is Dr. Sunil in this area. So I would request him to show some pictures as well as discuss briefly how the autopsy is done.
Thank you, ma'am. Thank you for involving me with this beautiful seminar. I also want to thank the Stillbirth Society of India and Dr. Nuzhat for her kind introduction. Of course, thanks to all the panelists and the audience. So, ma'am, I'll show you some pictures after this, but the perfect way to do, I think there is no perfect way. As in life, we all search for the perfect way, but there is never a perfect way. So there are 4 defined published criteria to do fetal autopsies. One is Rokitansky's method, where we examine in situ and then we remove en bloc. There's Vercoe's technique, where the organs are removed one by one. Then there's Little's technique, where en bloc removal of thoracic, cervical, abdominal, and various organ systems. Then there is Gon's technique. However, the choice of technique depends on the person who is dissecting. I personally prefer a combination of Rokitansky's and Vercoe's, and I'll show you why if you go to the next slide. So, for example, this was a case which was a 39-weeker. The lady had 2 previous abortions. And imagine a 39-weeker, everything, she was all ready. They were all very excited about this baby. And then suddenly there was an intrauterine fetal death. You can see there is post-axial polydactyly. Can we go to the next slide, ma'am? So there was hypothalamic hematoma on autopsy. There was bifid epiglottis. You can see there is vaginal atresia. There's pituitary hypoplasia. However, and there was also in ultrasonography, there was hydrometrocolpus. Now, for an obstetrician, And for any physician, none of these can cause a fetus to die. Hydrometrocolpus does not cause a baby to die. Post-exit polydactyly does not cause a baby to die. Most of these anomalies, this is not a lethal anomaly. However, still the baby died. So it was devastating for everybody. And one of the things which we had to do was to, as a pathologist, is to ascertain why the baby died. So if you look, I took some sections from the pituitary, and when we did some immunohistochemical markers, we found that the baby had congenital absence of adrenocorticotrophic hormone. Now, I'm not talking, of course, I published it. I sent it to all the international journals, but they did not accept this paper only because there was no genetics workup. Genetics workup for Pallister-Hall syndrome was very expensive. I tried everything. I even tried to pay from my own pocket, but we didn't have, we unfortunately could not store the sample the way it should be for transportation. So that highlights the importance of genetics. It highlights the importance of being aware that how we must take this sample, how we must store this sample for perhaps genetic evaluation. And it's not about publication, as I said. The important thing is to create awareness amongst clinicians that a fetal death is devastating, and we must ascertain the cause, and fetal autopsy and genetic evaluation go hand in hand. Next slide, ma'am.
Just before that, I would like to mention that the beautiful dissection of these fetuses, you can imagine these fetuses, even if they are just 20 weaker, the all dissection images of Dr. Sunil are as beautiful. You can see the bifid epiglottis and even the brain. We know how difficult it is to fix the brain and just to see whether there is corpus callosum or not. So I really appreciate these images. And I think unless we have good histopathologists of this level, we cannot think of really getting such a staining for ACTH and so on. And secondly, the sentence which is below, which has been written by Dr. Sunil, I would like to everybody to bring attention to that. It is not only for acknowledgement of the hospital or the patient as such, but basically it shows the commitment, passion, as well as emotional attachment to the fetuses. So I would like, I think all obstetricians are aware, and they also feel very emotionally attached if there is stillbirth. But also for the young fetal medicine specialist, I think many times what happens, we do identify malformation and the fetus is terminated. And we feel that this is good thing happened to the family, that there is no such problem. They do not have a baby who will be handicapped or a problem. So many times we are excited about our prenatal diagnosis, but we should always remember that the family who has an abnormal baby, whether it's prenatal diagnosis or stillbirth, it's a very, very traumatic situation. It's a feeling of loss as good as any death, any other death of a postnatal. So we have to be very cautious. And if this reflects in your discussion with the family, and they feel that you are also as concerned about the loss, and then probably the good rapport develops, and then they may give consent to fetal autopsy on your request. So coming to this next slide. What is it? Okay.
Yes, ma'am. So this is just to show the technique, and why the technique which I use helps me is because you can see that when I do an in situ dissection, we can actually have a beautiful anatomic correlation. This was a family which had, there were 3 cases of unexplained fetal loss, 27 weeks, 29 weeks, and 35 weeks. In only one case, ultrasonography could show that there was a umbilical vein varix. Now, in all the 3 cases, it was unexplained fetal death. Nobody knew why the baby died. And had we not done a fetal autopsy, we could not have documented this. There's another advantage of documenting this, is because nowadays families have only 1 or 2 babies. And if they lose one, there is so much of unhappiness. And there is another problem with India is that, at least I have experienced in counseling, is that the families blame the mother. They say that it's because of the mother the baby has died, and there is a lot of social stigma. There is a lot of ostracism. There is a lot of problems with women. So if I give a diagnosis, if a pathologist gives a diagnosis that it's umbilical vein varix which has caused the baby to die, there is no need to worry, you can have the next baby. So it helps the family. It removes a lot of pressure from the mother. I don't know, but I have seen women cry in front of me and say that, doctor, please help me. Please tell me that this is not because of me. Otherwise, my husband will divorce me. I mean, this is so traumatic.
Yes, I agree. And that's why we tell that when the baby is growing in the womb, neither the mother, neither father, nor the obstetrician, nor the mother-in-law has any control over the baby's growth and development. So we had to tell that everybody is equally responsible or not responsible for the fetal outcome of the pregnancy, especially when it's malformations.
Yes, ma'am.
So these umbilical varix, and see again the beautiful dissection. As Dr. Sunil mentioned about DNA-based diagnosis, that is very important for these cases, especially even with this Pallister-Hall syndrome. There, if DNA-based diagnosis is there, then next time prenatal diagnosis can be much earlier, and there is no need for we wait for ultrasonography to see whether there is polydactyly as 14 weeks or so. Before that, we can get diagnosis. And hence, we have to have DNA-based diagnosis. And Dr. Shagun can tell what could be the, how it can be useful.
I think Dr. Ratna.
Ratna, okay. So
yeah,
I think here
that's okay.
So Ratna,
So,
okay, Ratna, please go ahead.
So
Sorry.
it's already been alluded to previously, because that's the gold standard and the definite diagnosis. And just taking the simple example of osteogenesis imperfecta, you wait till the second trimester to identify the phenotype on the ultrasound. And if it's mild, you may not identify it then also. So therefore, if you've had a previous pregnancy where the fetus was affected, it's important to take a fetal sample. Whether we take the fetal surface of the placenta, and in that, along with maternal cell contamination, you have to do that test because you want to make sure you're testing the fetus. Or also what you can do is take a piece of the skin of the fetus. We do that also for ease of accessibility, but it should be all before the fetus has gone into formalin. And very often we see that the family may not be ready for the testing then, at least stored the DNA. Later, when they are more settled, etc., they come back to you. If you don't have the DNA, you cannot help them. Because we know that some cases, say, of osteogenesis imperfecta are autosomal dominant. That means there is one change in the gene. So there the recurrence risk is 6%, and you can do the specific gene mutation at 11 weeks. There are other cases of OI which look just like this, but they are autosomal recessive. And that means there are two changes, one inherited from each parent. So here the risk of recurrence becomes 25%. So you have to identify the specific gene. And that is why it is important. How it is done, I have told you, and why it is done also, I have told you.
Okay, thank you, Dr. Ratna. And again, what she has told, I would like to say that osteogenesis imperfecta, one feels it's a one disease, but basically there are 20 genes. So there are 20 types of osteogenesis imperfecta, and severity of each disease and each patient and another two different affected children in the family may be different. So you cannot just rely on ultrasonography for prenatal diagnosis, and DNA-based diagnosis is very important. So here I think Dr. Ratna wants to...
Yeah, this is just a case, ma'am. If you just bring on the other pedigree, I'll say it together. So see, okay. This was a family where their first child was okay, and the child had so-called decreased bones and fractures. Now, when we did the testing, so every case may not be an OI with decreased bone density and fractures. So here, it could be hypophosphatasia. So because we had the DNA of the fetus and we did the testing, we identified an autosomal recessive osteogenesis imperfecta, but there was also a variant for hypophosphatasia. But the fetus did not have that because that was a heterozygote. There was only one variant. There should have been two. So until you do the testing, you will never identify what is happening in that family. And that becomes very, very important. So I know this is complex, but I've just put it very simply to make you understand the importance of genetic testing and storing the DNA. If the family says, we don't want to do the test now, we are distraught, then you can explain to them, we will just keep the sample, take their consent, and that sample stays for 10 years. Nobody throws those samples away.
Yeah, so the DNA is very sturdy, and you may remember the movie where the dinosaurs were brought to life and so from DNA stored long ago. So I think few years is not a problem, and most of the families, they may say that we do not want any other child, but sometime or the other they come for next pregnancy. And the complexities of exact etiological genetic diagnosis and there are various investigations, maybe we can look at some later time. So this is another case, I think, which highlights
a similar case where there was a lot of dysmorphism, and this was a late fetal death. They did not do the autopsy, but all we told them, because it may not be possible everywhere, but all we told them was take the photographs, keep a sample. We guided the obstetrician where the baby was to be delivered. And they did that. And just with these photographs, we made a diagnosis and confirmed it on the DNA samples that was saved. So this was like a virtual autopsy. So things are possible. We just have to think about it and understand the importance of this, because this was also an autosomal recessive disorder.
So DNA-based diagnosis is equally important even for disorders where prenatal diagnosis can be done by ultrasonography. Still, because then we can provide early prenatal diagnosis during next pregnancy. Otherwise, one may feel that we can look for polydactyly during next pregnancy by ultrasonography, but it will take little longer time. So now, Dr. Amita, what can be the sample stored for DNA analysis? We had briefly discussed in between. Dr. Aradhana said that they stored cord sample. So different.
Yes, we usually save a piece of cord, placental tissue, fetal skin, or heparinized blood.
Right. So I think if you take blood from the umbilical cord, preferably should be stored in EDTA, because then heparinized blood is necessary for culturing cells, and EDTA blood will be good source of DNA. Also, the umbilical cord, cut umbilical cord, as Dr. Aradhana said, would be a very, very good source. And I would like to say that just put it in the plain vacuum. So you want some sterile container, so plain vacuum. And maybe Dr. Shailja wants can provide how they do sample storage as well as clinical information.
Ma'am, for clinical information, since the genetic diagnoses are very complex, so we should try to give it's the completeness of phenotype that is important. So whatever information we can provide, right from the pedigree analysis to the family history, to the maternal history, like history of consanguinity, any history of previous baby being affected, or congenital malformation, genetic disorder or something, or maternal significant workup like serology and etc. Along with this, any ultrasound findings.
Yes, that is very important. Ultrasonography reports are very
growth patterns of the baby. If once the baby has delivered, was there any external examination done? The findings of that, any pictures that has been taken, X-rays, autopsy, or histopathological exam. I mean, the completeness of phenotype.
Right. So full autopsy is very important, but otherwise, again, to stress, photograph, radiograph, and piece of umbilical cord and cord blood in EDTA. Sometimes if we get fetus, we also try to take blood from the heart by just putting a needle, and then cardiac blood can be very, very useful as a source of DNA.
One thing more, ma'am, if the patient agrees, the family agrees, and amniocentesis, if they agree for an amniocentesis in between. I mean,
yeah, so if it is already intrauterine fetal death, then I would also suggest that if possible, please do amniocentesis and store the sample or also culture the samples, which can be a source of DNA. But even if you have done amniocentesis, again, whatever postnatal samples can be collected should be collected. So the messages are that malformation syndromes are, even if are diagnosed by prenatal ultrasonography or autopsy, genetic diagnosis is very, very important. And if there is fresh stillbirth or whether it's intrauterine fetal demise, all those can be presentation of genetic etiologies. And as you will keep on looking for a genetic diagnosis and those list of genetic disorders which can be present as stillbirths will keep on increasing, and you have to know about these disorders so that the importance of autopsy can be stressed. Dr. Aradhana has already said that they asked the pediatrician to see the baby and photograph to be stored. So do you want to add anything else? And do you give the sample of umbilical cord to the family, or you store in your department or pathology lab, something? I think this is a very important thing we should come up with all centers.
Try to convince the parents and family members to
yeah, but will you like to give the sample to them, or because if they are not ready to go do the test,
to go for the test, we hand over the sample to them and ask them to bring the report of the
and if
test.
they are not ready, we can say.
Yeah, ma'am. If they are not ready, we generally do not take the sample.
So I think we should, as a policy, if the Stillbirth Society comes out some guidelines about SOPs after stillbirth. So in that it could be a storage of sample in the pathology department or somewhere, probably they can be there with some, without payment, but some information which can be accessed later on or can be given, something we can think about it, because storage is very important.
That can be done only after a set protocol has been given to the hospital.
I think we should work on that type of protocol.
Yes.
So
yes, one thing I want to ask, whether we can store the umbilical cord in ringer lactate apart from
you can just store it normal saline, sterile, any vacutainer, or you can just, even if a dry piece of cord is there, we got dry piece of cord from the family at home, because many people store the umbilical cord and hang it above the cradle or something. So we can extract DNA from the dry piece of cord as well. But if you put it in normal saline, store at 4-degree temperature, that's okay. Now coming to the now coming to the second part of autopsy is like doing histopathology. And for us also, very good histopathology of autopsies is sometimes difficult, taxing, costly, experts are not available, but this is very, very important from some disorders. So I would like to ask Dr. Sunil, why histopathology is very important, giving some examples.
Yes, ma'am. Thank you. So usually in any unexplained fetal death, fetal autopsy is very important. As Dr. Ratna had mentioned earlier, that there are very few lethal congenital anomalies. So, and syndromes can cause fetal death, but they are not every syndrome can cause a baby to die. So apart from trisomies, hypoplastic left heart syndrome, and encephaly, the baby will not die. So it's very important that every case of fetal death, every case of stillbirth be examined. And as we have mentioned here, cystic diseases of the kidney is a very good example to show how pathology helps. So this is a diagram which I have made just so that it's easy for everybody to understand. Conventionally, there are 4 types of renal cystic diseases: Potter type 1, 2, 3, and 4, or also known as autosomal recessive, autosomal dominant, renal dysplasia, and obstructive renal disease. So in Potter's type 1 or autosomal recessive polycystic kidney disease, we can see that the cysts are perpendicularly oriented to the surface of the kidney. And they are usually, this is how it looks. I'll show you a histopathology image. In type 2, the cysts are dispersed throughout. In type 3, there is an additional feature of cartilage which is present, and type 4 is very similar to renal dysplasia, except the fact that there is no cartilage. So can we go to the next slide, ma'am? So this is a case which showed you can see there's a membrane in the bladder, and this led to an obstruction. And there's a cystic dysplastic kidney, and this is the histology of the kidney. The renal tissue is completely destroyed. There is lot of cyst formation. There are no glomeruli. There are some isolated presence of glomeruli, but there was no cartilage here. In the next slide. So the right-hand side, you can see renal dysplasia. So the pale area which you can see there, that is the cartilage. So there are mesenchymal islands, and this is renal dysplasia. On the right side is autosomal recessive polycystic kidney disease. You can see that the cysts are oriented perpendicularly. And in autosomal dominant, you can see that there is a loss of renal parenchymal architecture. So it's by histology, we can give diagnosis of renal cystic diseases, even skeletal dysplasias. So I think, yeah.
Yeah, right. So histopathology is very, very important. And by expert, that is very important. Fetal ultrasonographers should know that when we make a diagnosis of cyst in the kidneys, then there can be very many types and the risk could be different. Similar another presentation is of heterogeneous etiologies is arthrogryposis. So Shagun is going to show some interesting cases of pictures of these cases.
So as ma'am mentioned, so arthrogryposis is again one of the common findings which we find in babies coming for autopsy. So in fact, in our series where like we have more of mixed bag, like fetuses which are terminated and also IUDs. So we have in fact found that a very high proportion, around 15% of these babies are having arthrogryposis. That is a deformity involving more than one joint. So this is actually etiologically heterogeneous. Like there are so many hundreds of conditions which can present like this. Sometimes they are obvious, like it could be part of a skeletal dysplasia. So if we see the photo, we do an X-ray, we can find it. Sometimes it may be trisomy 18 and you can pick it up on karyotype. But then in some cases, it may be something, a diagnosis which would require a detailed workup.
Will you like to do histology in these cases?
Yes, ma'am. Yes, ma'am. So that's what, in fact, these are the 3 cases where, in fact, it was the histology which gave us the diagnosis. Yes.
That's really important. And then probably molecular diagnosis for these cases.
So otherwise,
you can see the pictures, they are usually not clinically, like phenotype is very homogeneous, but still
it's very non-specific.
Very many. So again, to stress the importance of histology, and probably a higher level of histoimmunochemistry also may be required. And I think this NIMS hospital and Nizam's has a very good histopathology department. Another such a heterogeneous etiologies is hydrops, and regarding hydrops, again histology would be very important. So Dr. Jaiman can.
Yes, ma'am. Can we go to the next slide, ma'am? So as Dr. Shagun has already showed some histopathology images of arthrogryposis, I will show you the importance of hydrops and the importance of doing stillbirth fetal examination. This was a macerated baby, and you can see most of the times when you get a macerated baby, the pathologist would say it's macerated, we won't get anything. But I want to stress, and I hope there are pathologists here, I want to tell, and this is the example here, that even in stillbirth, even in macerated stillbirth, we can give histopathological diagnosis. And this was a Gaucher's disease, which was diagnosed on completely macerated baby. Every organ was macerated, but when I took sections, each organ showed these beautiful PAS positive inclusions, and we counseled the baby and it helped. The next slide, ma'am.
So many storage disorders, lysosomal storage disorders, can present as hydrops. So
Hydrops.
what is this one?
So this one is actually a cytomegalovirus case. Clinically, so it was hydrops. The clinician thought it's infectious mononucleosis, but they couldn't understand why. Usually infectious mononucleosis will not cause fetal death. So they send the baby for autopsy. And I want to stress again here, although every organ in the kidneys, the lungs, all of them showed cytomegalovirus inclusions, but I have to stress that in this particular case, I was alerted by the placental inclusions first. So when I saw inclusions CMV bodies in the placenta, then it alerted me, and I looked at each and every other organ, and I found beautiful inclusions everywhere else. So this also highlights the importance.
So basically, it can be 25% risk of recurrence of hydrops or 0% as in this case CMV.
Exactly.
So diagnosis makes a lot of difference for the family. So how can we make genetic diagnosis of such heterogeneous group of disorders, especially the genetic testing? Shagun may like to talk about it in brief.
So these kind of heterogeneous disorders like
so maybe Shagun, can we take it when we are going to talk about exome sequencing, because we already discussed about autopsy, and I think we have to take care of time. Just Ratna's experience about diagnostic yield of hydrops.
So this is again from the same data. So there were 76 fetuses here who had hydrops, and we had a diagnostic utility in 55. And then I took some additional data also of a total of 194. So it's more or less the same. About 60 to 65%,
right.
we have a diagnostic yield.
Yeah, that is with autopsy, but without exome sequencing.
Yeah, without exome. This is mostly
so
without.
We can next take up, I think now again would be more. Dr. Amita, regarding hydrops, when should we mention about the risk of recurrence? If you see hydrops in ultrasonography or stillbirth, Dr. Amita or Dr. Aradhana may respond. Because hydrops means most of the people feel it is immune hydrops, Rh incompatibility. I think there is some connectivity problem. So basically you have to remember that hydrops can be because of genetic etiologies. And Dr. Jaiman talked about CMV's infection from placenta. So any more, he wants to talk about another case where histology gave a clue.
Yes, ma'am. Yes, for example, this is a histology and actually placental examination gave us the clue that this is the Beckwith-Weidemann syndrome. This was the placenta showed what is known as placental mesenchymal dysplasia, and placental mesenchymal dysplasia in 30% of the cases of PMDs are associated with Beckwith-Weidemann syndrome. On the this is the baby with post-axial polydactyly, omphalocele, and even the organs were, most of the organs were above 90th centile, but placenta gave the clue here. Next slide, ma'am.
So overgrowth syndrome, and this placental dysplasia can also be mesenchymal, can be seen in ultrasonography also. Sometimes that gives a clue, but histological diagnosis will be very important.
This again, I want to highlight, this was actually a VST case. I just want to highlight the importance of placenta. This looked like PMD, but it's not PMD. This is placental, confined placental mosaicism. And this alerted me, and we actually could conclude by this that this could be a 22q deletion syndrome. So there's a paper by Dr. Diana Bianchi on NIPT. I would request all the genetists to maybe take a look at that, and others. The importance of placental examination, confined placental mosaicism, which looks very similar to molar or very similar to placental mesenchymal dysplasia, but it is not. and it's a CPM, and by this we can actually give one can do a 22q deletion and give a diagnosis.
This is a very great diagnosis and really gives message about importance of histology, especially considering genetic metabolic disorders. In fetuses, because of ultrasonography, we are more comfortable with malformations, but many metabolic disorders also can be very important, and histology is very important. So coming to those malformations which we're talking about, Dr. Deepti, how can congenital malformations be associated with stillbirths?
Good evening, all. So we can look at the external malformations such as polydactyly, or in some cases, there can be neural tube defect on external examination. Ma'am, next slide, please. And on internal examination, like in this baby, there was congenital diaphragmatic hernia. So in cases of isolated diaphragmatic hernia, the risk of recurrence is very less. It is around 2%. But in some cases, like in this family, there was history of spontaneous abortions. And on karyotype, we found a marker chromosome. So this is the most common recurrent chromosomal abnormality, which can be seen in carriers of balanced translocation. So in this family, the prenatal diagnosis is very important. So we can offer. Like in this case, the diagnosis is of congenital high airway obstruction syndrome. So the risk of recurrence is very low. So on the basis of examination of fetus, we can provide the family the exact risk of recurrence. Next slide, please, ma'am.
So these are hyperdistended lungs which can be seen on ultrasonography.
So in this case, we can see that the fetus has substantive of eyes and there is a sandal gland. So we did MLPA, and MLPA showed that there was trisomy 21 in this fetus. In this fetus, there was limb body wall complex. The entire right limb was absent, and the left limb also has some distal aplasia. In this case, there was neural tube defect along with the cystic kidney. So this was a case of McElgruber syndrome. And on cut section, we can see there are multicystic kidneys also.
So Dr. Shagun, can you answer this question, and we can be fast now?
So there are some internal malformations also which can actually present with stillbirth. So some of them being like holoprosencephaly, severe hydrocephalus or hydrancephaly, and then we could have renal agenesis leading to pulmonary hypoplasia, or a large diaphragmatic hernia again with pulmonary hypoplasia, and sometimes some critical cardiac lesions. So all these may not be apparent externally. Then again, this reiterates the importance of doing an autopsy and trying to look for that particular malformation.
So internal examination is very important, as important as histology and external examination. Yes. So sometimes the fetus, like the family is not ready for detailed autopsy. So Dr. Deepti, can we do some imaging of the stillborn baby?
Yes, ma'am, we can do CT scan because this is less costly compared to MRI. This can show periventricular calcifications. However, MRI is better than CT. So we can see holoprosencephaly in this scan. Also, nowadays we can do whole body MRI. So MRI of other organs may also yield important information regarding the various malformations. So if the family is not...
that can be a substitute to autopsy, like where the family is very, very sensitive about not letting the family, the fetus to undergo autopsy, then whole body MRI can be useful to some extent. So Dr. Amita, can the imaging facilities be made available for 24 hours in a tertiary care hospital? That is a very important, useful thing. And Dr. Ratna, have you done some whole body MRI cases, because your hospital has patients who may have better paying capacity? And do you think it can be useful in some cases?
So, well, yes, if we have CNS anomalies, and especially if they are posterior fossa, then the MRI will help. But you have to have somebody who's really dedicated to looking into fetal MRs. And also it has to be done immediately. Otherwise, there's autolysis and all, and we tried it one odd time, and the fetus comes to you late. Everything is not an in-house delivery. So there are challenges, but one, at least I don't find it as good as doing an actual autopsy.
It has lots of limitation. Again, the gut anomalies,
and it's much more expensive.
So not really that useful. On the contrary, I find that whole body CT scan and then 3D reconstruction is very useful for bony anomalies and classification of skeletal dysplasias. So how do you convince? The most important question at the end in every obstetrician would feel, yes, you have told everything, but our families don't agree for giving the fetus for autopsy. So
I think two things are important. Giving the family a little time, being able to connect with the family and speak to them nicely and softly, and giving them the respect. It's their baby who is not there anymore. And I think it's not difficult to connect with them.
So I think avoiding words like fetus and autopsy. So I usually say that even if the baby is not alive, still give the baby for evaluation and examination. So dead and autopsy words preferably can be avoided, so that we can be very happy.
And I think they also want to know what happens to the baby. Can you give them the baby back for their final rites? If you don't give the baby back, how you are taking a consent and what is happening? I think those are important things to convey to them.
And placenta and umbilical cord examination. We usually do not get placenta from our referring obstetricians. So again, to remind that placenta should be sent, as Dr. Sunil has really gave the importance of placental examination. Some common aneuploidies, I think we have less time now, so we can just rush through and show that he has shown that some chromosomal abnormalities are found in stillborns. And how you suspect those that would be chromosomal abnormalities?
Even by placental examination, we can pick up, ma'am. So I think, Dr. Girish can say.
Dr. Girish is not here. I have taken his pictures from his some presentation, and like such type of small clues like trisomy 18 like hand. And exactly regarding, so some external malformations may not be very obvious, maybe subtle, but as Dr. Sunil, like placenta histology, you can get some clues. So histology again is important, and to stress you that many of the fetuses with trisomy 21, sometimes you may not be very sure that it is trisomy 21, and the phenotypes of fetuses. This is from the paper of Dr. Kirisha, where he has shown trisomy 21 fetuses at various gestation, and you can see that diagnosis of trisomy 21 just based on the external examination may be difficult, and again stresses the importance of fetal chromosomal analysis and genetic testing. Dr. Deepti, in this case, would you advise genetic testing for these type of malformations?
Yes, because meningocele can be associated with trisomy 13, 18. Sometimes there can be partial deletion. Also, some monogenic conditions such as Meckel-Gruber syndrome, Zober syndrome can also present as a neural tube defect.
So even if we have made malformation, diagnosis of malformation, etiology of malformations is very important, and for that genetic testing is necessary. Very important presentation is sudden IUD. The family was like the pregnant lady had shown, the doctor consulted antenatal checkup a few weeks ago or a day ago, and then there is sudden IUD. So Dr. Aradhana, do you have such experiences, and what is the reaction of the family?
Yes, ma'am. Very often we do have such experiences, and we are really puzzled and more concerned when the cause is not obvious. When there is explained stillbirth, still we can be sure that we can prevent. We can be ascertain that we can prevent the next pregnancy turning to a stillbirth, but. It is more of a problem when it is unexplained.
What are the clues to the placental causes? I think obstetricians are best person to see that preeclampsia and everything, like lot of protocols now for so placental causes they are monitoring, and still there is a stillbirth, and that is the most important situation. And here we want to show dramatic results. So Shagun can talk about fetus with normal growth and suddenly there is IUD. So no placental cause is there, unlikely. So how to reach the cause?
So in fact, this would be the scenario where we would really be thinking of a genetic cause. And then these genetic causes can be of different types, chromosomal problems or various single gene disorders also. So again, I think this would be kind of the gist of what all we have been saying, that we have to go through the different steps. Ma'am, next slide we can go to. So just review all the history, review the ultrasound findings. Ma'am, next slide, we'll just see the flow chart. I think it would be clear.
So I think you talk about mainly like exome sequencing diagnosis is the
yes,
most important thing.
Yeah, we can take, I thought we could take it later, but yeah,
Okay. I think we should have to hasten a little bit. So we want to mainly highlight about sudden death due to some
so sudden death, one of the causes where there is nothing, no clue, there is no anomaly, no other finding, are cardiac arrhythmias. So as Dr. Ratna also mentioned, the long QT syndrome. So now there are studies saying that approximately 10% of unexplained IUDs are because of inherited cardiac arrhythmias. And making a diagnosis of this is really important, because this is one of the parent may be having the same mutation, that parent may be at risk of sudden cardiac death, and then the risk of recurrence in such families.
Arrhythmias. This is, I think, this will be highlight of this panel discussion, that those obstetricians, those who have faced that suddenly there is IUD and the family was very disturbed, that we were following with you with a whole antenatal checkup and suddenly the baby died. So storing the DNA and submitting to the genetic testing can identify these genetic causes of arrhythmias, and these arrhythmias in fetus can cause sudden death. And this is the diagnosis is very important, not only for the patient and the doctor, but also the parents, because some of the parents also may be at risk of sudden death. So this, I think we have already discussed, that store the sample, and I think Shagun, we can go ahead, I think. So what we told about exome, what about diagnosis arrhythmia is by doing the genetic testing, and there we tell that you do the exome sequencing. So Dr. Deepti, can you briefly tell what is exome sequencing and what is the power of it?
So exome sequencing is like, as the word denotes, it is the sequencing of genetic information which is there in the protein coding genes. So it can be of various types, like whole exome sequencing. So it is a set of all the protein coding genes, or it can be a targeted testing, including a set of selected genes depending on the phenotype. Like if the fetus is having a phenotype of osteogenesis imperfecta, then we can sequence a selected panel of genes. So likewise, it may differ. Also, if you are doing whole exome sequencing, then the diagnostic yield may vary from 8% to up to 40%. So it depends mainly on the selection criteria. Like we are taking a stringent criteria, the fetus has a malformation that is already known to have some genetic etiology, then the diagnostic yield will be more.
But all these diagnoses which we had not expected, you can get those diagnoses where you cannot think clinically that this could be a possibility. You cannot think by ultrasonography or histology also. So you can get such correct diagnosis by doing exome sequencing. So Dr. Shagun, I think you had a lot of data about exome sequencing in fetuses. So this, please show your experience, share your experience.
Actually, our data is not really for stillbirth. So this is more of
all fetuses with
all
malformation.
fetuses. So some of them with already ultrasound detected malformation and terminated, or some of them are of course stillbirths and IUDs also. So in fact, we have found in our population a very high percentage of these babies. So it's nearing around 50%. So 50% of these babies are having a single gene disorder, and this can be diagnosed, or the genetic diagnosis can be made by doing an exome sequencing. So once we have done a basic cytogenetic evaluation by karyotype or microarray, we should definitely think about doing exome sequencing. In fact, I mean, this may be become a first line test soon for our population, at least, because we are finding high proportion of autosomal recessive disease in India, because we are an endogamous population, and in southern part of India, in fact, there is a lot of consanguinity. And so we have more of these single gene autosomal recessive disorders in our babies. So this test
So
is.
do you think this exome sequencing, which is very fruitful, can it be done later on, like if the fetus like autopsy is done, and then later on, because the cost is too much or the family is disturbed, so how long we can postpone this exome sequencing or microarray?
So, ma'am, as you said earlier, that I mean the DNA is such a stable molecule that once we have taken the correct fetal sample and extracted the DNA, we can really store it for a very, very long time, and we can do this test whenever the family is planning for the next pregnancy. So we at least encourage them to come back to us before planning a next pregnancy. And
Before
at that
planning,
point,
that is very
yes,
important. Before
yes.
planning is very important. So many times the family immediately may not want, but we
Yes.
should call them after 3 months and so on, and then get the further testing done. Otherwise, the family comes due after next conception, and then exome sequencing not only needs money, but it also needs time. So it's a little, it cannot be like within a week or so. So there may be reporting time may be longer. So Dr. Shagun, can you tell about a case? Dr. Ratna also had talked about novel genes, and this your interesting case. What was the diagnosis?
Yeah, so the other important or the other interesting part of doing exome sequencing is that we may find something new also. So in fact, this was one such baby, very non-specific phenotype of kind of a hydrops-like presentation. They had a previous stillbirth, so a neonatal death with intractable pleural effusion. And then the next pregnancy, they came to us with pericardial effusion. And then they terminated this baby. And then what we found in autopsy was something I had never seen before. So these were like these grapes, kind of grape-like lesion. They were really studying everywhere. I mean, these images don't do justice to it because they were so collapsible. The moment we touched something, they just disappeared. So they were really everywhere, on the pleura, under the lungs, on the mesentery, in the pericardium, everywhere. There's nothing externally you can see in this baby. I mean, this is almost a normal-looking baby. So here, but because there were two babies similarly affected and these findings were there, we actually went ahead, did whole exome sequencing, and we found a nonsense variant in one particular gene. Ma'am, we'll go to next slide. So that is a Serpin A11 gene. And actually this gene belongs to a family of genes of which one common, disease which we know is Serpin A1 related alpha-1 antitrypsin deficiency. So this is just to show how we filter the data and all, and this is the variant. So baby was homozygous, parents were heterozygous. So this this protein or this gene is similar to the Serpin A1. We'll go to next slide, ma'am. So Serpin A1.
So this is basically equivalent to a big research, but it is for patient care. So every single case may be a candidate for research, and the research may be directly helpful to the family, like bench to bedside, and hence every case with a very interesting finding is very, very important to be further evaluated, not only for the patient, but for the science as well.
It's just to show, ma'am, why we, how we went about when we saw this variant, how we correlated it with histology. In fact, this baby had a lot of good histological findings. We saw all these problems in the extracellular matrix, which we were expecting, because this is basically a protein which inhibits proteases. And then we did some immunofluorescence studies on the baby's lungs to show that indeed this protein is not expressed. Kind of prove that this is the gene which is causing the phenotype. Ma'am, you're on mute. Shubha, ma'am.
So basically, this is a big research job, and the whole message of this particular panel discussion was to tell that when there is a stillbirth, obstetrician should realize that there are many, many more other causes than perinatal poor care, and probably getting the exact etiology will help to the patient and family. And it's not that and they blame on the obstetrician. Sometimes I think obstetricians may be blamed by the family about poor management or something or mistake. So there, I think this can be very useful. So otherwise, most of the times what happens, the antenatal care was okay, but baby didn't cry. And then what we is told, baby did not cry, or there is lungs were hypoplastic without doing autopsy. But I would like to ask Dr. Sunil that when it is told that baby ne ganda pani pi liya tha, so can histology really be confirmative for meconium aspiration as a cause of neonatal death? Because as we are doing to identify genetic etiology, we also want to confirm that any other non-genetic causes also to be ruled out. And
Yes.
these are the pictures.
Yes, ma'am. So as you can see, I'll show you two cases. One is this meconium aspiration. You can see that baby was normal. Everything was normal. 39 weeks and baby didn't cry, and we found meconium in the lungs. Next one, ma'am. So here histology is showing. And this is another case where there was, this is another case which is actually in press. This is to show that sometimes one can find severe bacterial infection without any fetal response. So this baby, everything was normal. Every organ was normal. Maceration, but despite maceration, every organ showed, every blood vessel showed bacterial colonies. And gram stain was positive. And we could say that the baby died because of severe septicemia. So it was not a clinician's fault. It was, this couldn't have been diagnosed because there was no
diagnosis would not be possible without autopsy and without a fetal pathologist like Dr. Sunil. I think it's really must be very challenging. So lastly, I would conclude with this case, what I was saying, that in the beginning, there were 2 stillbirths from a consanguineous family. And it's really tragic to see that both being attributed to just birth asphyxia. When we were, and most of the times the patients are sent when both the babies are like, there is no sample, nothing, and the parents only come for the advice regarding recurrence. So there was cord around neck. So it was told that the baby had cord around neck and fetal distress was there. In the second baby, there was polyhydramnios, and then again they were told that the fetus had birth asphyxia. But see, there is consanguinity, and after the first baby also, even if there is cord around neck, the possibility of genetic etiology could have been suspected. And now, because the baby's samples were not available, we tested the parents. And we tested the parents because if the baby does not take respiration, then his or her muscles may be weak. So if you think of muscle disorders, in the website called OMIM, which is a free database of genetic disorders, everybody should look at this website again and again. So there are many disorders with muscle weakness. And because we did not have samples of the baby, we tested the parents. And husband and wife both were found to be carriers of a pathogenic variant, a mutation in a gene which is for Niemalin myopathy or congenital myopathy. So basically, in this situation, the birth asphyxia was not the cause of, it may be the cause of death, but the cause of birth asphyxia was genetic disorder. And it's a genetic muscle disorder. And if you go and see about this disorder in OMIM, you will find that most of the babies have decreased fetal movement, and that can give rise to polyhydramnios, and most die of respiratory failure during early infancy or during neonatal period. So basically the point to stress is that every birth asphyxia or every stillbirth should not be attributed to perinatal causes. And if there would have been sample of the baby, it would have been very great. But now this is a rare situation where even if the sample of the baby is not available, you can take care of, you can study the parent's sample and then by exome sequencing. So some other time we can talk about details of exome sequencing. So the messages are think of genetic disorders, draw pedigree, visit online Mendelian inheritance in man. This is a free website. If you put Ominum on Google, and keep the rare diagnosis in your list. Encourage the families for fetal autopsy, and for this, communication is the best tool. The senior most obstetrician, if he or she talks to the patients and families, I think the getting fetus for autopsy will not be difficult. And again, I would say that don't leave it to the residents to talk to the family. If they talk to the family, then probably it may have the reverse effect. Of course, everybody, residents learn by seeing their teachers, and if the senior obstetricians really are committed for the fetal autopsy, we can be there can be lot of correct diagnosis and prevention of stillbirths. As I said, no stillbirths so that is our objective, and I think we can achieve to some extent by making a correct etiological diagnosis of each stillbirth. So thank you very much. And I encourage everybody to join Society for Indian Academy of Medical Genetics for more information regarding genetic disorders of not only stillbirths, but for genetic counseling for many other disorders where prenatal diagnosis is possible. So I will stop sharing and
thank you, ma'am. Now I'd like to invite Dr. Anupriya Kaur if there are any questions in the chat box to answer. Dr. Anupriya.
Thank you, Shailja. Am I audible, Shailja?
Yeah, very much.
So are there any questions, Anupriya?
Yes, there are one or two which I thought would be good to be discussed on the forum. Actually, Dr. Aradhana is asking, ma'am, that the scoring system for preeclampsia. So is there a scoring system for stillbirths? So probably what I'm getting is that she's trying to ask which fetuses should be evaluated for autopsy, should be taken up. Is there any
every stillbirth should be for autopsy, except maybe like somebody coming from periphery with arrested labor and breech delivery, probably very hardcore. I'm not obstetrician, but they can decide that. But otherwise, every stillbirth should be evaluated and every placenta should be evaluated.
Yes, ma'am.
Ma'am, I meant to ask if the patient is not ready, parents are not ready to go for fetal autopsy, as there is in most of the cases, even after proper counseling, then what should be the minimum protocol which we should go for?
Yeah, so a photograph, front, back, side, close up of face and limbs, that is one thing. Radiograph, whole body infantogram, AP view as well as lateral view. And then, as I said, a piece of umbilical cord. If you cut 1 or 2 centimeters umbilical cord piece where the family should not have any objection, store it in the sterile vial, maybe vacutainer with or without normal saline at 4-degree temperature. So these minimum things I would suggest, and maybe Shagun and somebody. And as I said, cord blood is very important.
You can do the placenta histopathology.
Placenta histopathology, there should not be any objection. I think that's very important. And we can also tell that we can give back the fetus for further religious process, religious whatever ceremony. So they would, if you volunteer that, they may not ask. So if you volunteer and tell that we can give you back the fetus for whatever religious activity we have to do, then they may agree. So we have to really preempt what should be their main objection for not giving the fetus, and also talk about recurrences. That most of the there also we usually say most of the times next baby will be all right, but probably there may be recurrence, and then we have to really help. So always talk in a positive way. Even after stillbirth, they should not think that there will be next stillbirth again, and that's why we are telling. We should tell next baby will be normal, but in case. So trying to what I would say, that always probably you keep on giving more now, give enough time, usually you get the fetuses for autopsy. Not 100%, but still many of
yeah,
them.
we started. Yeah, at least we have now started convincing them for all these array of tests. And I hope that in future, more of them, more of the parents and families would be able, would be aware
Autopsy
and
would
would
not be very
to
costly usually. Autopsy will not be very costly. Further
Yes,
tests
ma'am,
are costly. So autopsy usually should not be very costly.
but
So,
it needs pathology support, ma'am.
yes, but you have to encourage and pester the pediatrician and pathologist. So every hospital, medical college has good pathology, and I wonder they will be always be able to do fetal pathology also. And I think a pediatrician, if he's involved in the external examination, so this is something which will be no cost basis, can be established at every medical college and should be established at every medical college. So something very easily doable. Pediatrician can do about this.
And OMIM that we have learned from you, ma'am, during our training, that has helped us a lot. And we are always going for it after seeing this morphologic feature. We have started consulting OMIM.
Thanks.
Yes, ma'am. I think persistence is very important. If you persist as a clinician, if you persist the pathologist without maybe hurting the pathologist's ego, keep persisting. I'm sure every institute would have pathologists who would be interested. I think a pathologist.
You keep the fetus, to call pediatrician and call pathologist, and then
Exactly.
say, now you will do, or we do. Even obstetricians can do, and they can watch, and then they can take away the samples for histology.
Ma'am,
in fact, ma'am, one question.
Yeah.
Actually, I was going to ask your question only, Shailja, to ma'am, that Shailja is asking when to go for cryoexome versus fetal exome. In fact, I wanted to, when you say this
Anupriya, kuch cut raha hai awaaz.
Yeah, your voice is breaking. I think some internet issue is there.
So I think we will need more time for detailed exome microarray. So it is 8:10. So maybe Dr. Tamkin can tell us when to stop.
My quick question.
Okay.
Just a quick question.
We are all enjoying
This
it.
is
That's
a
why.
repetitive question. This is a repetitive question. If we have a fetus, first pregnancy in which the fetus had a disease for which we know the genes, or somehow like, for example, like non-immune heart drops, or madam has asked sometime like epidermis lysis bullosa, and no workup was done in the last pregnancy. Now the patient comes up for the second pregnancy. Now what to do? Should we go for like?
Dr. Shagun can answer, or Dr. Ratna can answer.
So what we can do in such a situation is that now that we have exome sequencing available, so if we have a diagnosis of the first baby, at least a clinical diagnosis, and we are suspecting that it's a genetic condition. So again, if the baby sample is not there, at least for some conditions, we could do exome sequencing of the parents. This is especially relevant for the autosomal recessive and X-linked recessive condition, whereby you may find the parents or the mother respectively to be carriers of that particular mutation which has resulted in the phenotype in the baby. So now this testing is available. So this is basically carrier testing of the parents using exome sequencing. But this is going to be useful in specific scenarios whereby you make a diagnosis of the first baby, like you know that it is a genetic condition, and you have like a geneticist has seen, and then it is looking like a condition which is mostly autosomal recessive or X-linked recessive because the parents are healthy. Rarely there could be some autosomal dominant condition whereby parents are mildly affected and not clinically symptomatic, and the baby had a more severe phenotype. So there also such testing would be useful. So again, I think it would be best for a geneticist to, take a look at the previous baby's records, photographs, or whatever information is there to decide that this is a family which can benefit from such a testing. But this testing is now available, and it can help in finding the mutation and help in guiding prenatal testing, pre-implantation testing for the next pregnancy.
What about suspected microdeletion deletions, or that all that we can detect from a microarray or a karyotype? So in that case also, if we suspect something like aneuploidy or something in the baby, and
Yes.
so
You do a karyotype of the parent. Please don't do microarray of parents, because we get so many reports where microarray is being done on asymptomatic parents, and that is incorrect. It's an expensive test. It's double the cost you're doing it for the parents. It's very simple to remember. Microarray is to pick up abnormality. It will not pick up anything normal. So your parents are normal, so you don't do a microarray, at least as a standoff. We do it sometimes, but we do it for very, very specific situations. But as an obstetrician, you can do a karyotype for a parents because you're looking for a balanced translocation where there is a risk of recurrence. So if it's something like a trisomy 18, a trisomy 21, which say was never tested in the baby, we know that overall the risk of this happening again is not there. It's 1% or less than 1%, which you could never then, do any test to evaluate. But when we are looking for a significant recurrence in the chromosomes, one of the parents is a translocation carrier, and there you do the karyotype of the parents. That is what is important. And another thing, I think, just to add on to what Shagun is saying, where there's these funny family histories, it's important to refer that patient to a geneticist. The only reason for that is, today I saw a family where 2 children had died in the neonatal period, and they were roaming all over the place. We had done a carrier screening, and it was interesting that when we saw the records, in one discharge summary, one line had mentioned that the DNA of the baby had been stored. So that is enough for us. You've done the carrier screening, you found a variant, you have a DNA of an affected child, you confirm there, and that's all you want. And as an obstetrician, sometimes what happens is, I don't know, when they come to me, I have this, that. I said, I don't know anything about it. The ultrasound shows a fibroid. I don't understand that language. So that's why when there are these complicated histories, the advantage of sending to a genetics doctor is, one, we are used to going through, files and files of old data, and the eye is able to pick up what is really required. And that, I think, is the relevance.
Also very important,
Thank you,
that pre-pregnancy.
Thank you, ma'am.
Every consultation should be pre-pregnancy. If the family comes during pregnancy, then it is really challenging to do everything together within the limited time frame. So this is very important.
I asked Dr. Chitra to give vote of thanks. Dr. Chitra?
Sure.
Good evening, everybody. It is my great honor to present the official vote of thanks on behalf of the Committee for Study of Genetic Causes of Stillbirth. And I'm very grateful, and we had a wonderful evening today. I'm grateful for the panelists for their precious time, who have spared their precious time. I want to thank Dr. Sunil Jaiman for taking out time from a busy schedule and gracing our panel today. And I would like to thank Dr. Ratna Puri, Dr. Shailja Singh, Dr. Shagun Agarwal, Dr. Amita Pandey, and Dr. Aradhana Singh for gracing the occasion. And we had a wonderful discussion today. And last but not least, I would like to thank Dr. Phadke, who has been the guiding force behind this webinar discussion today, and Dr. Shailja, who is always the most, my go-to person and always very helpful. And thank you so much. And I would like to thank the audience today for attending this, and I hope you had a learned evening. You picked up so many important points here, and which we will all thankfully carry on in our clinical practice. And thank you very much. Thank you, everybody. Good night.
Thank you, everybody.
Good night. Dr. Neelam, would you like to add something? And Dr. Nuzhat?
Yeah, really, I congratulate Stillbirth Committee for Genetic Causes of Stillbirths. They have really organized a wonderful session, and I hope everybody must have benefited from it. Thank you so much, everyone. Thank you.
Dr.
Thank
Reza?
you. Thank you, everyone.
Thank you. Thank you.
Have a
Thank
nice
you.
weekend.
Amazing evening, amazing evening. Thank you so much.
Thank you. Thank you. I think more centers come up with that is the success of the seminar.
Some
And
very
everybody can
important
approach
messages,
Dr.
yeah.
Sunil with their
Very
histological
important messages
slides
have been
and
given.
tele-education.
Yeah, and very important messages have been given today. And I hope we'll be able to replicate this webinar with other societies as well. Yeah.
Thank you.
Thank you so much.